I hope you can hear me. Welcome everyone in the room. Just a note, if everyone could mute their microphones, so we don't get too much feedback and too much external noise. So everyone mute their microphones, please. So welcome everyone to this talk on on the newly qualified physician associate. Really, what to expect? What sort of tips can we help with that transition? This is being delivered from the group that we've set up called the Southwest Physician Associate Network. We're really proud of this network. It's quite new to us, but we've set it up initially as part of the Health Education England Physician Associate Ambassadors that represent the Southwest. So we set it up from the Southwest PA network, but it is obviously open to all people that would be interested in this, because there's quite a lot that we're going to talk about, which is probably generally transferable to a newly qualified physician associate wherever you are joining us from. So welcome again. So my name is Alex Stevens. I'm a physician associate. I'm a UK trained physician associate. I qualified from Birmingham. I'm just going to keep letting people in while I'm talking. Qualified from Birmingham in one of the first cohorts, actually. So I'm qualified about 12 years now, and in practice in acute medicine, secondary care, and also involved in physician associate education. I've been involved in the University of the West of England programme for about 6 years, and before then I was also involved in the Peninsula Medical School, so the Plymouth Physician Associate Programme. So welcome again. Next slide, please, Abel. So thank you everyone for taking their time out of their Friday evenings for joining us. So as you can see, we've got a really good agenda lined up actually, and we've got some really good speakers. So all of the speakers are physician associates, registered physician associates, UK trained and practicing, a range of experiences and a range of backgrounds, but we'll hear about that as we go through. As I said, I'm Alex Stevens at the very top. I'll be facilitating this event really, so I'll be sort of introducing the speakers, and then trying to sort of handle and facilitate questions and answers. So as you can see, each talk we have about 15 minutes for each talk, and then a space for questions and answers at the end as well. Throughout each talk, if you do have questions come to mind, please sort of hold on to them. Feel free to type something in the chat if you can. Perhaps not everyone has access to the chat for some reason of this magical Microsoft Teams that I still don't fully understand. So if you do have a question and you can't type it in the chat, please feel free to raise your hand. The raise your hand symbol is on the menu as well. But towards the end of each talk, we probably have a few minutes for questions as well. So that's a good time to raise your hand if you have a burning question at that point, but also at the very end as well. So I hope that makes sense. I'm looking forward to this. We're really looking forward to this. And we hope, obviously, you find it useful. We hope that it's useful. This really is part of the sort of emphasis and the ethos of setting up this physician associate network, especially for the Southwest where we are. But obviously, it's good to have a network, and it's good to be able to contact each other, feel supported, and really maintain and nurture that as we move forward throughout the different times that's going to be ahead of us. So Yeandle is going to be our next speaker. Eden is here. Eden, if you can unmute your microphone and say hi, just to check that works.
Hello.
There we go. Hi, Eden. So Eden is going to be talking about making the most of your first month. I'll hand it over to you, Eden. Thank you very much, and we'll get going.
Great, thank you. So next slide, please. So as I said, I'm Eden, I'm a physician associate. So just a bit about me. So my background was radiotherapy and oncology. So that was my undergraduate degree. I then worked as a therapeutic radiographer as a band 5 for about a year, then got a job as a band 6 mammographer in breast care. So I did a PG dip to be able to do that. And it was from here that I then decided that I did want to further my practice, and that kind of medicine side of things took my interest, and therefore did the PA course. So I did this at the University of the West of England, and I graduated last year, so kind of August last year, then sat my nationals in September and thankfully passed. Next slide, please. So I'm just going to talk about applying for jobs first of all. So some of you might have already started to done this or even got your job. So I started looking probably right at the start of the second year, actually, mostly just to see what was kind of out there and what kind of jobs there were and what was the requirement. So I use NHS jobs for all of my searches. There are some other websites, I think, like Indeed and stuff like that, that also have jobs, but they will all be on NHS. So I would suggest that's the best place to look. You can also send email reminders. So with keywords, say physician associate, and I happen to put within 40 miles of Bristol. So I'd get emailed of any jobs that would meet that description. Quite often they send quite random ones as well, but it does give you kind of first insight of the ones that come up, giving you more time to have a look and then apply for them if it's something that sparks your interest. Next slide, please. So despite all of them being on NHS jobs, I did find that actually quite a few of the jobs were all different formats. So I applied for 3 GP physician associate jobs last year, and they were all quite different. So one required a traditional CV, which I hadn't really seen in healthcare before. So that was one of them. Another one was just kind of attaching a personal statement. And then the one that I found that's kind of most traditional is via track, where it's all different sections, which makes it quite methodical and easy to fill in, and then attaching a personal statement. So it's quite good to just have a couple of things ready. So just jotting down, some things as you go through university, so then you're not starting completely from scratch when it comes to your application. Next slide, please. So as I said, I applied for 3 jobs, and I was fortunate enough to be offered an interview for all 3. So kind of my main tips would be just to start early. So, as soon as you see a job that sparks your interest, to apply or start applying for that job, and don't leave it to the last minute. Really helpful as well to ask someone else to look over it, especially a clinician, whether it's a PA or, any member of the healthcare team. Really, an extra pair of eyes is always good. And just keep reading the job description. This is what you need to evidence. All the points in the job description are things that you should evidence of how you've done these things. There are lots of points, so you're never going to meet all of them, and sometimes it's quite repetitive if you were to meet all of them. So it's just about, choosing the main ones and, showing how your experience has met these points. So just an example, quite a lot of them say, to be able to formulate diagnoses and treatment plans. So you could say, during my placement, I conducted histories and exams, and then I would propose a management plan, which I discussed with my supervisor, and then just expand on these experiences to meet the job description. Next slide, please. So as well as, meeting the job specification and things like that, it's also good to say things about yourself. So, qualities, interest, hobbies, also, how you deal with stress. Healthcare can be a challenging environment, and a lot of employers like to know, what you can do in your spare time that helps you kind of cope with the challenges that comes with the job. And also what kind of separates you from other candidates. So whether it's travel, have you been abroad somewhere where you've done kind of, marine biology experience or volunteering, clinical experience, or anything with sports, but obviously you need to then relate it back to the job. So an example that I've used, so I was a competitive swimmer and went to the Commonwealth Games, and having that in my background really helped provide me with a strong foundation and an insight into the importance of team working to get, a good quality result. So then relating that back to healthcare, why is teamwork important? Why is it good that you're a good team member and everything like that? So just kind of basing your previous experiences, even if they're not healthcare related, into those kind of qualities that they're looking for. Next slide, please. So where I was and what I'm doing now. So as I said, I passed nationals in October, and I think I started in GP the next day. So it's quite a quick turnaround. So this provided me, within GP, a really great deal of experience. I saw all patients, kind of all ages. There was no filter or restrictions to the patients I was seeing. obviously on one hand, this is really, really good because it provided me with so much experience of these conditions, but also, you know, it was quite imperative as a newly qualified that I was going to ask for help if I was worried about a patient or if I wasn't sure. And I feel like particularly as a PA, as we're dependent practitioners, it's really important to have discussions with your supervisor because, you know, they can be really daunting, but it's important that we're practicing safely. And I think if things aren't, you know, you started the job and things aren't quite how you want them to be, just to set a meeting with your supervisor and just discuss, you know, would you want more supervision? Do you want some joint clinics with your GP supervising, anything like that, just to kind of set boundaries and, you know, limits and work together with them on how you can both benefit, you know, as a PA and also them by having a PA. Next slide, please. So I have worked in GP for 5 months, but I've recently accepted a job in A&E. So the main reason for this was just to kind of get some more hands-on experience, having been quite newly qualified and perhaps in a slightly more supportive environment. And I've always had an interest in emergency medicine. I think for me, this is, you know, one of the main benefits of being a PA as well, that although we don't have to rotate through specialties, we have got, you know, as junior doctors do, we have got the freedom to actually, you know, change should we want to try something new. And for me, this was one of the main things of why I think, you know, being a physician associate is so good, you know, getting all this diverse experience and it will really benefit in the future. So I start there next week, so it's all quite new and exciting. So hopefully I'll be able to talk a bit more about that when I've been there a while. Next slide, please. And that's it. So if anyone's got any questions or anything they'd like to ask, feel free.
Well, thank you very much, Eden. If anyone does have any questions, like I said at the beginning, please raise their hand and we'll pass over to you, or type it in the messages. But to get everyone going, I've got a couple of questions, Eden.
Mm-hmm.
That's skeptical. So, as a student, especially as you were in your final year and sort of the end was on the horizon, did you know where you wanted to sort of end up? What particular area you wanted to end up?
No, I didn't at all. I was quite open to it, to anything really. So at the time, only GP jobs were coming out when I was applying. So I did feel that was slightly restricted, but then again, I was always interested in GP, so it wasn't a negative thing. But no, I think I was quite open. And again, I think that's one of the benefits of being a PA is that we can, you know, read job descriptions and think, actually, yeah, I think that would suit me quite well.
Absolutely. There's so many benefits to being a physician associate that I know we could all speak about. Thank you, Eden. There's a question that's popped in the chat from Hayden. Thanks for this. So we've got a question that says, so did you apply for jobs before you knew you were qualified?
Yes. Months before. I think I accepted my job in June. So this is before I knew that I'd passed university and also before I'd even sat the nationals. And that's absolutely fine. A lot of employers, you know, do state, you know, you can apply before, you know, you've sat your nationals. And also, even if it doesn't, I think it's quite important if you're interested to email the person on the job advert just to say, you know, I'm looking at qualifying hopefully the end of this year. Would you be open to having applications for these type of people? And often they will. I've seen quite a lot that actually have come back to me saying, yes, absolutely. I think the GPA job I'd actually had said that they'd wanted a qualified physician associate. So I messaged them saying, you know, I'm going to be newly qualified. Is this still something I should be applying for? And they kind of encouraged the application. So the answer is yes, definitely.
Yeah, really good to hear, Eden. I would completely agree with that advice. Hayden, I hope that helps answer your question there. We've got a couple of questions. Yeah, it does. Hayden's just said, brilliant, thank you. Got a couple more questions coming. So we've got a question from Nancy. Do you think it's, so Eden, do you think it's been better starting off in primary care as a newly qualified physician associate over secondary care? So primary versus secondary care?
I think it's really individual. So I think everyone's responses will be different. So I think personally for me, no, I probably would have preferred to start in secondary care. But again, I think that's more down to perhaps the practice not having had a physician associate before and perhaps just needing a bit more information on how to support a PA. you know, it was a really good experience, but I think personally for me, GP was slightly more, you're very independent there, whereas I know colleagues of mine who work in GP and I have completely different experience and are very happy that they started off in a GP. So I think again this comes down to when you're applying for jobs and you're at interview stage, you know, speaking to the employer about what do they know about PAs, what support are they providing for PAs, you know, do they have supervision for PAs, all that kind of thing, so you know before you start that all that is set in place for you.
Absolutely. Yeah, we've thank you, Nancy said thank you. I think that really helped with that question, and it's a good question. Talking about the expectations around primary care and secondary care, for everyone in the room, if in case you haven't come across it, there's a really good free resource called Physician Associates Transforming Healthcare. I put the link in the messages here. It's a really good resource to point almost employers in the direction of as well. It's a free resource. It's like a consultancy resource. We've got a couple more questions coming in as well. So, Wakur, I hope I pronounced that right. So, would you recommend applying for multiple jobs at once, or perhaps one at a time?
So I think if multiple jobs, you know, you have an interest in all of them, then there's absolutely no harm in applying for multiple jobs. You know, I applied for 3 all in the space of probably a couple of weeks from each other. So I think as long as, you know, you're interested in them and, you know, you're quite keen to work in that specialty, then yes, you could, you know, I'd recommend applying for more than one at once.
Yes, absolutely. So casting your net out wide, and yeah, we had thank you as well. So you answered that question really well. Another question from Master Villa. I hope I pronounced that right. So how was it making the decision to change jobs, Eden? Were there any contractual obstacles with that?
So the decision to change job wasn't easy. I really enjoyed GP. You know, primary care gives you so much experience in so many different conditions, and you know, you do learn very quickly because you're just seeing everything and you're not, you know, kind of confined to a specialty. So it wasn't an easy decision, but I think it was the right one at the time. No, there weren't any contractual obstacles with that. Basically just had a discussion with employer and going from there really. So obviously it depends on what your contract says when you sign it, but usually there's not really anything unless they're providing you with, you know, funding for certain things. I can't imagine there'd be much, you know, many obstacles with that.
Yeah, thank you, Eden. I'm sure that helped. Yeah, we got to thank you as well. So thank you for that. Yeah, so people are in very, you know, there's a range of situations students could be in. As I know there are sponsorship opportunities around the country, and that will have some sort of contractual obligations. But it's all in, if you like, it's all in the contract, it's all in the fine print, and there is some flexibility within that. So really read the documentation that you're sent if you are in that position. I hope you find that link that's in the chat useful as well to everyone. No more questions at the moment. Again, if you do have any questions, we've got a couple of minutes. We've got 3 minutes still before the next speaker. But Eden, I've got another question. I mean, starting out in primary care, certainly, let's say within that first month when you're really just getting into it, what do you think the biggest learning points were for you at that period? You know, what was it that really opened your eyes in that first month?
That's a very good question. Gosh, there are just so many things. I think it depends as well on what. So as a second year physician associate student, I was given kind of my own clinics and stuff like that. So that was quite good to get that initial experience. And although obviously not the same as kind of working independently, seeing kind of undifferentiated patients and, you know, having a supervisor that agrees with your plan and your management plan and stuff was definitely helpful. But I think being in that first month was, you know, just having these widely presenting undifferentiated complaints of all ages, whether they were children, months old, or people in their 90s. And I think it was just knowing, you know, when patients are unwell and when they're not. I think that was something that kind of opened my eyes quite a lot, is, you know, just to know when someone needs kind of further investigations in secondary care, and if they are quite unwell, or whether actually it's better just to kind of observe for a few days and go from there, and how to do that safely. I think that was the thing that kind of opened my eyes the most in that first month. There's obviously in secondary care, if you want a chest x-ray, you can usually get it that day, whereas in GP, can be within a few days, but quite often it's not an urgent x-ray, and just things like that. You don't have everything accessible quickly to you. Bloods come back the next day, things like that. And I think that's what I found quite different.
Yeah, thank you, Eden. Sorry to put you on the spot. Yeah, absolutely. So primary care, there is a lot more dealing with clinical uncertainty within that, which is what you were saying. Absolutely. We've got 1 more minute. I'm going to ask another question because we don't have any more in. So it was a steep learning curve, as you said, going straight into primary care in that first month. What were the sort of best strategies you used to sort of make sure you were learning the most out of that month? Was it things like reading when you after your shift? Probably you're quite tired as well.
Yeah, I think so I definitely think reading about stuff I wasn't sure about. So probably one of my weaknesses would be dermatology, as through quite a lot of our placements we don't see an awful lot of dermatology, whereas in GP a lot of people present with a rash, and I think that was one of the things that I would definitely read a lot more about at home. I think it's difficult, and it probably sounds really cliche, but I think you just learn by doing it. And obviously you need to ask for support and things when you do need it. But also I think, doing the course actually does provide you with a really good foundation knowledge that you need to start off. And I think sometimes we underestimate ourselves and think, oh, I don't know this, but actually I think we do. So I think, I think just seeing the patients, and often, people present with the same thing. So you will have seen someone with, right upper quadrant pain 3 times that week, and each time you learn and improve on how you've dealt with it.
Thank you very much, Eden. So we just had a question in, but I'm going to ask Wicco if we can hold that question till the end, because it's 25 past and we're going to move on to our next speaker. So please please ping that question across at the end as well, if that's okay. So Eden, thank you very much. I hope everyone found that really useful. It was great to hear about the sort of tips and experiences you can share. So Eden, thank you very much again. And right now we're going to move on to our next speaker. So please can I introduce Ross Raymond-Jones, coming to talk to you about understanding your employer's expectations. So Ross, if you're there, over to you.
I'm here. Hi, thanks Alex, and thanks Eden. That was really insightful. And I think it's quite interesting seeing what job opportunities are available around different counties. So here down in Devon, there's barely any GP jobs available. And when I qualified 2 years ago, it was all based in secondary care. So it's really interesting seeing that observation. So my name's Ross Raymond-Jones. I'm a registered physician associate, qualified 2 years ago. My background prior to becoming a PA was adult nursing, where I did a short stint once I qualified. And then upon qualifying as a PA, I've worked in a range of areas, both in secondary and primary care. I've also worked as a physician associate ambassador and done some work with the physician associate program at Plymouth University. So today I'm going to talk about understanding your employer's expectations. Next slide, please. So I'm not an employer myself. So this topic is about my presumptions and from my experience in GP and secondary care, trying to get an idea of what our employers want from us and what they expect from us. So in order to be the best PA that we can be, we need to be able to gauge what these expectations are. And our employers' expectations are going to differ, and we're going to go through a number of different facets and nuances about that. I could just talk about very generic things about employer expectations, but all those types of things you would have built on in your previous courses and during your physician associate program. So I'm going to focus on the nuances that are linked more to a newer profession, such as PAs. And throughout this talk, when I refer to an employer, I could be referring to, I'll use it interchangeably, so I could be referring to a trust, to a GP practice, or a more local level, it could just be referring to your supervising consultant. Next slide, please. So I've come up with a few different scenarios that you might come across when you're looking for jobs or when you start your first job. So the first one is your employer may have worked with a PA before. Sorry, it may never have worked with a physician associate before and have quite an unclear understanding about the role. With it being a new role, that's quite understandable. The second scenario is each employer may have only dealt with a small handful of PAs in the past, so have a very small sample group of PAs to reference to. And the third example and scenario is each employer uses PAs slightly differently. For example, as Eden touched on, in GP, each general practice or each supervisor might expect something different from you. One GP practice might want you focusing on home visits, the next might want you working on the on-call list, working on prevention or chronic disease management. So we'll go through each of these and touch on each of them. And as I said before, these are kind of unique issues to a newer profession. So in terms of if you joined an employer that has never worked with physician associates before, this is sort of a blessing and a curse. Next slide, please. So it's a blessing in the fact that you have a blank canvas to work from. So because they've never worked with a PA, you haven't really got a box that you have to fit into. There's no kind of pre-expectations apart from what they've learned about the role already. So the reason this is a blessing is because you can shape this role into whatever you want and really try and truly show your value. The downside of this is that you're going to have to do all the hard work and the initial grind when you're introducing a new role into a new culture. So you're going to have to teach your employer and other team members about the role, and you're going to have to prove your worth rather than your worth being handed to you based off previous experience. The second scenario, based around if your employer has worked with PAs. So most trusts now have employed at least one or two PAs, but they're usually only a small sample. So the consultant or the director of the trust would only have reference from maybe 1, 2, 3, 4, 5 different PAs. And these PAs might have different education levels, might have different experience. They might really excel and take on excess responsibility and tasks, which could lead to your employer having really high expectations about what you should be achieving. And this can come in difficulty because if they've only ever employed quite experienced PAs, their expectations are going to be higher than they probably should be if you're newly qualified going into that role. I think the way it works is, I think it's difficult. Either way, you're likely to expect to fit. You're going to have to fit into a box because they're going to have these pre-expectations, and it's important that you talk to your employer about their expectations and about your expectations, because that initial communication is really important. That tends to be a lot easier if you're in a smaller culture, such as a general practice, because you've got kind of more one-on-one time and you've got less people that you need to gauge your expectations. But going into a multi-practice or a PCN or a trust, sometimes that can be a bit more difficult. Next slide, please. So another difficulty in managing your employer and team members' expectations is that as a PA, you don't have different titles to showcase your experience. So doctors will have the foundation year 1 and 2, specialty doctor, registrar, etc. While PAs don't have this, although some trusts have created some form of experience structure, such as having a physician associate and a senior physician associate to kind of gauge the rough level of experience level. But there's no universal standardized model for this. So your expectations for an FY1 and a registrar would rightly so be quite different, just as the expectations of a 10-year post-qualified PA should be very different from a newly qualified physician associate. And the difference is that a junior doctor or an FY1 doesn't need to tell anyone that they're a new doctor. It's general knowledge. It's on their uniform. It describes their level. They're a junior doctor, so you know they're in the first year or two post-training. Unfortunately, as physician associates, we don't have this. So it's so important when you're starting in a new ward or practice and when you're working with new supervising consultants that you make it really clear that you're a newly qualified physician associate, because then those expectations are set and laid in stone. And then hopefully in your practice or trust, you'll have some way to identify yourself as newly qualified, because you don't want to be given too much than you can handle. And I know it's tempting when you start to try and take on everything to try and prove yourself. But especially if you've worked somewhere that's only worked with a few PAs or haven't worked with any at all, then to really explain to people that you are newly qualified, because not only are you new to the world of medicine, it's very likely you'll be new to how that individual system works, and that goes the same with experienced PAs. I've spent I'm 2 years post qualified now and just entered a new job, and I feel like I'm a student again because there's a whole new system. So anyone I meet, I say, I haven't been in this trust for the last year or two. Please bear with me. And then people's expectations about what I can do and how quickly I can do them are set early on. And then I can start proving myself as I get used to the system and the team that I'm working in. Next slide, please. So we've covered why your employer's expectations might differ. Now let's have a kind of closer look at some more specific qualities that your employer is probably looking out for. And obviously this is not an exhaustive list and they're all quite generic, but these are kind of the main ones that if I were an employer that I deem kind of most important. So as you see on the slide, the fundamentals are your employer would expect you to work only within your scope of practice, be honest and professional, document well, which we'll go into a bit later on with one of the other speakers, and of course maintain your registration, such as doing revalidation exams and keeping up to date with your CPD. And one of our other speakers will be covering that in a bit more detail later on. Next slide, please. So your scope of practice will change year on year as you develop new skills, new competence and confidence. And as I mentioned earlier, it's really surprising how easy it is to bite off more than you can chew, especially in your first few weeks. Because if you're anything like me, you're really trying to prove yourself as a new profession, as someone new to the world and new to the practice. And you're just really keen to showcase what value you bring to the team. It's of course really important to do your best and take on as much responsibility as you can, as long as you feel competent and confident to take it on. And sometimes there's definitely a grey area, and if you're ever unsure, always seek further support from your team, because at the end of the day, we're here to serve our patients, and they must always be our first priority. So we've always got to put our ego and our image sometimes on the sideline and prioritize our patients. Working outside your scope of practice, purposefully or accidentally, could potentially lead to patient harm, as well as harm to the profession's image. So try not to get carried away, and the main thing is to trust your instincts. Most of the time, when we feel like we're out of our depth, we usually are. And I've had quite a few experiences, especially when qualifying, where I thought I was competent and confident at something, but there's this niggly feeling in my stomach that I was out of my depth. And you've got to trust that instinct, and don't be afraid to communicate that discomfort with your team, and try and get that support. And hopefully that support is available in your first jobs. I think by talking to your seniors and communicating with them and speaking to them when you're unsure of things can really build respect from your seniors and peers, rather than taking on unnecessary responsibility, which initially might look good, but when something goes wrong, it's quite easy to lose that trust, and that's really hard to regain sometimes, especially as a new profession. Your peers and your seniors don't expect you to have all the answers, but they do expect you to practice safe medicine and seek help when help is required. This could be as simple as getting a peer or a senior just to review an ECG that you don't feel confident interpreting. It's important to remember that your PA training can't teach you all of medicine, and we shouldn't expect it to. Its aim is to provide you with enough insight to know what you know and know when you don't something. And by being honest and transparent with your employer and seniors is a brilliant way to stay safe, build trust with your team, and reduce stress, because then you're not going home taking that stress home with you. So I hope that was helpful, and I've covered a bit of insight into what your employers are expecting from you. A lot of it is common sense, but just the message I'd like to drive home is don't be afraid to communicate with your seniors, and hopefully Eden and other new qualifieds can resonate with that. Next slide, please. So good luck, everyone, finding jobs, starting your first jobs. I'm happy to answer any questions that you have, be it about employer expectations, or if you have any specific questions about a PA that's 2 years qualified, who's worked in both primary and secondary care.
Well, thank you very much, Ross. And I might just add on here, if you do have any questions in the audience here, please write them down, because we've got 20 seconds, and I do want to stick to time here. I'm a stickler with that. So write down your questions. We'll have time at the end for it. Okay. But Ross, thank you very much. That was, as you said, about Eden's talk, really insightful actually, and it's just really useful to hear how important it is to understand expectations and to be transparent, and to have that open channel of communication with your employers, new employers, and so forth. So thank you, Ross, once again, and I'm sure you've had some really interesting experiences, which I think would be really useful to maybe ask questions about at the end and talk a bit more about. But right now, Abel, we're going to move on to our next speaker. So next slide, please. And here we go. It's Abel himself. So
hello.
Over to Abel, the portfolio and CPD. Over to Abel.
Thank you very much, Alex. Hope you can hear me all right. So yeah, my name is Abel. I've qualified as a physician associate, UK trained, about 4 years ago or so. Since qualifying, I've worked only in secondary care, but in quite a wide range of different specialties, from acute and emergency medicine to respiratory cardio, a bit of surgery as well. And now currently I'm in my fairly permanent post in geriatrics. So I'm just going to talk to you a little bit about portfolios, CPD requirements, things that you should be keeping up as a qualified PA or newly qualified as well. So first, what is a portfolio? I'm sure you all know, you've probably done some in one shape or form or another. You would have kept a portfolio, at least within your physician associate training. Essentially, it's just a record of significant events or significant things that you've carried out, either as practical procedures or certain cases that you've seen. So it's just a collection of events sort of showcasing what you have done, what you can do. And it's a means of taking this portfolio everywhere you go with you, just to provide some evidence for how your scope of practice has developed over time. You can take it with you wherever you go, as I said. So even if you are to look for new posts or within, let's say, a different department within the same trust, or if you'd like to go from secondary to primary or primary secondary care, this is a collection of events that you can take with you and showcase to your possible future employers as well. Now, it is a professional requirement. So if you are registered with the faculty under the Physician Associate Manager Voluntary Register, a part of the registration, keeping up with the registration, is to maintain a portfolio, as well as maintaining evidence of continued professional development. And there's many different ways that you can keep a portfolio. I'll talk a little bit about it a bit later, but there's essentially two things that you need to keep in mind. So for your professional continued registration with the PA MVR, you need to document your portfolio and CPD requirements through the Royal College of Physicians CPD diary. But for your own collation and collection of CPD, you can maintain that whichever way you like. It's worthwhile to check with if you work in primary care with your GP practice, or secondary care with your trust, to see if there's any specific platforms that they use. But if there isn't, it's not particularly very important which one you use. It's just important that you do have evidence of your CPD. So what can you put into a portfolio? Really, that's up to you. I would suggest put everything as much as you can in. So initially, you could start off with your scope of practice or your scope of work. So that's essentially your job plan. Whether you're full-time in a particular department, or if you split your time, let's say 50-50 doing education and clinical work. But also if as I had rotated, similar to how the F1 and F2s had done in my trust, my scope of practice and job plan involved the different rotations that I had throughout a year, just to showcase the different types of experiences that I've had. Also, your workplace-based assessments. These are things that you've probably all would have done during your training as well. For those who are newly finished or soon to finish, it includes many KEXs, practical procedures, so your DOPS, case-based discussions, as well as some feedback. And I'll go in through each of those a bit later as well. I think you probably would have done this during your training, but reflections are very, very important. I think it's a key element of your portfolio, because it shows almost a degree of self-awareness. As Ross alluded to earlier in his talk, there's no way that you'd be expected to know everything. No one does. However, you need to be able to showcase where your limits of expertise or experience are. But demonstrate that you have the insight to be able to identify areas that you might need to develop, write those down, and you can keep working on that. Whether it's interesting or challenging cases, or if it was a difficult event or something that was quite challenging to deal with within your clinical practice. It's quite broad. It's up to you to decide what to reflect on. But I think just the practice of reflection is very important, and it's definitely something that you should be adding into your portfolio. You can also add some extra clinical activities, so whether that's any clinical research that you do, writing papers, quality improvement projects, audits, really sky's the limit. All of these activities should be added in as well. And some 360 multi-source feedback, which I'll talk about a bit later. So mini KEX, for those of you who might not be aware, this is where a supervisor, usually should be at least registrar or above, who would observe the way that you interact and the way that you handle an assessment of a patient. So whether that's through history taking, examining, as well as discussing your management plan and being able to rationalize any investigations that you might suggest. It's really helpful because it does give you an opportunity to showcase a lot of different aspects of clinical practice, all within a single setting, from communication skills to examination skills, as well as evidencing your sort of thought process and how you would tackle or manage different patients with undifferentiated symptoms to a specific issue. Once you do complete the assessments, people are very busy. It's always worthwhile to try and get the form filled out as quickly as possible. Now, there's no specific types of forms that you need to use. I think the Faculty of Physician Associates do have a few resources on their website, and I have added some links in a bit later, should you wish to refer to them. But any means of documenting essentially what was assessed, the outcome of the assessment, any feedback that you can get, and obviously details about who your assessor was, are the main things to take home with you. So DOPS forms, these are direct observations of practical skills. These can be used, I would suggest, for more extended procedural skills. Things such as venipuncture, cannulation, maybe arterial blood gas taking. These types of skills fairly basic procedures would have been assessed during your program. However, it's still worthwhile to maybe keep a logbook, just so at least you can demonstrate, within your first few months, that you've conducted X amount of cannulas successfully. But the DOPS forms, as you progress and as you develop your skills a bit further, they could include procedures such as lumbar punctures or chest drains, joint manipulations or aspirations. These can be assessed by anyone who's competent in doing that procedure. And depending on, obviously, your trust guidelines or how your primary care practice is run, it's a good idea to get as many of these as you can. Usually we aim for about at least 4 to 5 or so, to make sure that, you know, someone is completely independent before they're able to do it without supervision. Again, these the DOPS forms, these can be found on the Faculty of Physician Associate website. There is a link a bit further on for you to hold on to these. Again, get them done as soon as you can after the procedure, because people do forget, or you might, you might forget. So it's worthwhile to get it done sooner rather than later. Now, case-based discussions, I think you've all would have done this or something fairly similar during your training as well. But this is also a really good opportunity to assess your professional clinical judgment. So this would involve you having a sit-down conversation, potentially with a registrar or a consultant regarding talking around a clinical scenario. And you can pick certain elements of that clinical encounter that you might want to focus on, or you could talk or focus on the whole assessment of a patient, but also gives you the opportunity to do it across a whole range of clinical scenarios. It really, I mean, sky is the limit. It's up to you to decide anything that you personally find interesting, or something that you might want to learn a bit more about, or research a bit more, or reflect on. This is a really good opportunity to get that down in writing, and also provides you a good amount of feedback to help you develop your practice in the future. So this slide is just showing almost, it's a timetable essentially, but we have something fairly similar that we're trying to develop within our trust, but it's almost a guide of the different types of workplace-based assessments that you should aim to try and do, predominantly within your first year, but also as you're continuing on, just to ensure that you're getting as much practice and you're showcasing your development as you are progressing and gaining more experience. So it could start off with, a few CPDs and mini KEXs within a 3 to 6 month rotation. And as you're developing more experience, then obviously the type of cases that you'd be discussing and your mini KEXs would develop as well, but potentially that their frequency might reduce. So this is just almost a guide that maybe you can consider that this is something you should be aiming to get at least a few done, maybe 5, 6, 7, or 8 within the first year of you practicing as a qualified physician associate. And finally, multi-source feedback is something that's always very helpful to get, because this provides an opportunity for your colleagues to see just to comment on how it is to work with you, if there's certain things that you do very well, if there's certain things that they might suggest areas for improvement. This is an opportunity for you to get that feedback so you can develop yourself. And this doesn't have to be solely from clinicians. It doesn't have to be just from doctors or your fellow PAs or nurses, allied health professionals, whether it's the therapists or the ward clerks or any administrative team. They can all help provide feedback. And in fact, the more varied and the more widespread it is, the stronger your portfolio will become. Again, there's no set form that you need to use to get your multi-source feedback. If you can't find something that you think doesn't work well, by all means feel free to create one that's tailored to your situation or what you might like to use. Personally, I use the one from the Faculty of Physician Associates paper-based ones. I know within our trust they have their own system that you can use, but I find this a bit easier. And regarding your continued professional development, as I said, it is a professional requirement. You need to attain about 50 credits per year. Now, this needs to be logged into your RCP CPD diary. So once you're on the managed voluntary register, part of your subscription helps pay for this. So this is something that you do need to use. It's about over a 5-year rolling period. You have to attain 250 credits. So that's about 50 credits a year. And these credits need to come from a range of sources as well. So you can't solely focus on just going to conferences or just reading journals. You need a minimum of at least 25 external credits over the course of 12 months. The CPD cycle runs from beginning of April of every year to March. Now, for those of you who may have started slightly before the cycle began, so if it was February, March time, you would need to start counting your CPD from the beginning of the next cycle. So from April, for example, April 2021 onwards, that's what would be counted. You can get an unlimited number of internal credits, so whether that's teaching within your trust or teaching within your primary care practice, that would all be counted, and you can get a maximum. You can use a maximum of 10 personal credits, so whether that's reading journals, writing papers, reviewing articles, etc., would be included within your 10 personal credits. And finally, so appraisals, this is a really important part of your clinical practice. You need to have one done. You should have one done every year. Appraisals aim to ensure that you're meeting the four domains of good medical practice set by the General Medical Council. This is a professional requirement and expectation that you can provide evidence that you're maintaining your knowledge, skills, performance, safety and quality, communication and teamwork, as well as maintaining trust. Appraisal should be done with someone who's a trained appraiser, so your institution will be able to provide you with a list of who to speak to. Try and get this arranged as early as possible. You should be having one every year. Also, it's likely that you'll need to have an appraisal before you're able to step up onto the next pay point within the pay band, so that's also another motivation. There are several platforms you can use. You should check your local guidance. I think at the trust that I work, we use something called PREP. It's just a means of documenting all the CPD, all the workplace-based assessments, your multi-source feedback within a form, and then you can review that form with a trained appraiser. It's usually a consultant. And you can also set your personal development plan. So that could be things that you'd be trying to aim to achieve within the following year. And then with your next appraisal, you sit down and have a look to see if you've managed to achieve all of those things. Prepare for it as early as possible. Try to prevent. It is quite a fair amount of work. So if you manage to do a little bit at a time, it definitely makes things a lot easier. But it is your responsibility to arrange it. So try and have it done once a year. I think I'm short on time, and I think that is all. Thank you very much.
So Abel, thank you very much. That was really useful, and actually you covered an awful lot in a short space of time. So I'd advise all of you, we're going to upload this recording onto the Southwest Physician Associate Network website. You can find that just through Google. If we'll put the link in, Abel's put the link in here. So we'll upload the recording. I'd advise go back and watch it as well, and write down some questions. We don't have enough time for questions on this one right now because I want to keep the time. But certainly I've written down some questions for Abel as well, in case other people don't. But please write down some questions and we'll go through them at the end as well. But I hope you found that useful. Maintaining your portfolio is really important. Maintaining your sort of professional development is really important. Right, time is ticking on, so we're going to move on to our next speaker now. So we've got James Willis, a Bristol-based physician associate. If we move on to our next slide, Abel, thank you. So we've got James Willis talking about developing a professional identity and certainly sort of the importance of teamwork. So James, if you're there, over to you.
Yes, can everyone hear me first of all?
Yes.
Yeah, fantastic. Okay. Yes, thank you, Alex. Some of you may know me slightly better as Jim, but I work as a GP PA in Bristol. And this evening I'm going to talk to you about how professional relationships enable us to form our own kind of professional identity and to establish kind of where we sit within the multidisciplinary team. Probably I should just throw in a small apology that this talk does contain a little bit of philosophy in it. So if anyone finds philosophy a bit boring, then I apologize in advance. Next slide, please. So first of all, I thought I would get people's brains going by posing a little brain teaser of what these two have in common. Now I realize that everyone's on mute, so I'll let you try and draw your own conclusions for a few moments. But where I was going with this is that on the left we have a new surgical robot at Southmead Hospital in Bristol, which is used to treat prostate cancer patients. It's one of the most advanced robots there is. And then on the right, we have kind of the forefather of what is thought to be modern robotics. And the tie between them is, of course, the name Da Vinci. So on the left, that is the Da Vinci surgical robot, and on the right is Leonardo da Vinci himself. And where I was going with this is that for most of the working population, it's becoming increasingly clear that some of the working tasks that they do will either be in the future, or perhaps more soon than we think, performed by a form of machine or robot. But, next slide please. We are not machines. So empathy, compassion, and trust are at the core of what we do as physician associates. I would say as a society, we're quite good at educating people to develop the hard skills, and particularly those who've gone to physician associate school, those who've gone to medical and nursing school, are excellent at the hard skills of analysis, decision-making, and analytical judgment. But what I would say is that recent research, particularly that was done by the World Economic Forum, has said that it's actually the human soft skills which are becoming increasingly valuable. Skills such as empathy, context sensing, collaboration, and creative thinking. And the research from the World Economic Forum showed that your ability to empathize with, connect with, and influence others is one of, if not the most pivotal skill for success within the workplace. By virtue of our role as dependent practitioners within the multidisciplinary team, we need to nurture these soft skills in order to forge successful, lasting professional relationships, not only with our peers, but also with our patients as well. Next slide, please. So I thought I would break it down into kind of three main headings around why professional relationships are important and what it is that defines relationships. And I think the first key thing to consider is purpose. So purpose means having a shared understanding between yourself, your junior doctor colleagues, your supervisor, of why the relationship matters. And that is the critical foundation upon which you build a relationship and use as a touchstone when, difficulties inevitably arise. In my experience, the most effective doctors, the most effective PAs, the most effective practitioners that I have seen are those who develop the confidence and the skill to discuss and establish a clear basis and intent for their relationship from the off. So my advice would be to all of you to be clear with your supervisor or the registrar or the junior doctor that you're working with, if you're clerking with them, and define from the offset how you see the purpose of your working relationship with them. Then I would suggest, particularly for those of you who are working closely with a consultant or with a GP, that you review this in an ongoing fashion. And Abel put up some very good information earlier about how often you should do this, particularly in your internship years and moving forward into years 2, 3, and 4. Next slide, please. And then I thought it would be important to talk about the type of relationship that we have in the workplace. So I quite often think that it's helpful to think about relationships along a spectrum. And within that spectrum are three main types of relationship. You have the transactional relationship, the interdependent relationship, and the transformational relationship. The transactional relationship is probably the most basic of the three. And I would like this to, when you're on your lunch break in your hospital or wherever it is you find yourself working, and you nip down to Costa Coffee to get yourself a coffee. Yourself and the cashier both have a minimum set of requirements and expectations from each other. You expect the coffee from the cashier, they expect the money from you. Even if you stop by that same Costa day by day, week by week, a simple transactional relationship can fulfill the needs of both of you. In the middle, we have interdependent relationships. And in these relationships, you need a higher degree of expectation in areas such as shared goals, shared knowledge, and mutual respect. Examples of interdependent relationships within the healthcare workforce could be surgical and post-operative care teams. They have shared goals in the management of the patient, and they have mutual respect for each other. Drawing upon my previous experience working on stroke and neurology, stroke physicians and stroke rehabilitation therapists are an example of an interdependent relationship. In these examples, each side of the relationship depends on the other for both individual and mutual success. And then finally, at the furthest end of the spectrum are transformational relationships. And this is the type of relationship that I would say I have with my GP supervisor and that the vast majority of PAs have with their clinical supervisors. Transformational relationships are characterized by the level of influence, mutuality, and vulnerability that is allowed and nurtured between both parties. In these relationships, we have to be open to the other person's point of view, and also to the possibility that their beliefs and their views will directly shape and impact our own. But equally, each person needs to be willing to hold the other person accountable to higher standards, even if that makes them uncomfortable. And that can mean being willing to initiate very difficult conversations, but it also means being open to being on the receiving end of the same type of conversations yourself. Next slide, please. So I thought we might pause very briefly at this moment just to consider what type of relationships we might have with these professionals. Clearly, there are some that we work very closely with, some that we work less closely with, and this will change depending on which situation you find yourself in, whether it's secondary care, primary care, or the like. So I think, have a look at this, have a think about what type of relationship you think you might develop with these individuals and how that then might shape your own identity within their teams. Next slide, please. The final point that I wanted to touch on was commitment, and I've put the little subheading there of even in the face of adversity. And if we think back to transformational relationships, so in other words, the relationship that most PAs will have with their clinical supervisors, these are the relationships that require most commitment of any along our spectrum. Because remember that in a transformational relationship, we must be open to the other person's point of view, but also to the possibility that their beliefs will directly shape and impact our own, and also to having difficult conversations when perhaps we disagree on a course of action. Powerful transactional relationships will always have bouts of discord and disagreement. On a day-to-day basis, there are always things that myself and my GP supervisor disagree on, but as a dependent practitioner, I'm open to hearing their point of view and hearing what they have to say, and they in return are open to hearing what I have to say, and in turn we learn from each other. And a committed relationship is always one in which both parties are committed to learning from one another and accepting that we are human and mistakes do happen. And going back to our man at the start of this presentation, Da Vinci, he said that learning is the only thing that the mind never exhausts, never fears, and never regrets. And I like to think that it's how we learn from mistakes, but also from one another's experiences, whether that be the interdependent transformational relationship that we have with our supervisors, or the broader relationships that we have with junior doctors, nursing staff. Learning from one another's experience is how we gain wisdom. And our final quote at the bottom of the slide there, once again from Da Vinci, is that wisdom is the daughter of experience. Next slide. So to kind of wrap up then, have you and your colleagues thought about what your relationship is within the team which you'll be working? So have you considered how your junior doctor colleagues see you as a practitioner? Do they understand you? Do they understand your role within the team? Do you understand their role? And do you understand how the team is going to work together? Have you thought about what type of relationship you have with your colleagues? Clearly, transactional relationships are not applicable for all of our colleagues, neither are interdependent or transformational. But using a specific type of relationship, depending on which colleague it is that you're working with, will help you to shape and steer that relationship. And how does commitment, or the lack of commitment, show up in your relationship? Clearly, in a transactional relationship, commitment is not one of the cornerstones or the foundations for success. But in the transformational relationship that we spoke about, that we might have with our clinical supervisors, commitment is very much a foundation upon which a strong relationship is built. So I'd like to close my kind of talk there, and obviously I'll take questions in the Q&A at the end. But I hope that was helpful, and I hope it helps you to think about the importance of soft skills, so empathy, compassion, trust and respect between yourself and your colleagues, but also to consider the appropriate type of relationship that you would have with your colleagues, and to think about really discussing with them how you see yourself working within your team on a day-by-day, week-by-week, eventually going on to a long period basis. Thank you very much for letting me speak with you this evening.
Jim, thank you very much. I'm a bit shell-shocked. That was deep, everyone. So that was deep for a Friday evening anyway. Very good. That was really interesting to listen to. And we've got about a minute actually. I just want to say that I feel like I epically failed. I did not recognize or know that was Da Vinci. So maybe I'm the only one. But
the robot or the person?
The person. But yeah, you really have reinforced the sort of the importance of those humans soft skills, those being a human, being a real person, and those softer skills that are so important for building up professional relationships with your patients, but also in the team you're working in. And teamwork and being a key player in that team and having and maintaining those teamwork relationships is so important for physician associate practice, as I'm sure you may all know from your experiences if you're students being on placements or practicing physician associates here. But it does all come down to teamwork and communication within that and so forth. So write down your questions for the end, please, everyone. Again, I've written down a few. But without much more notice, we'll move on to our final speaker now. I hope you've all enjoyed this so far. But our final speaker, this is going to be really interesting and really important to hear about. So it's about medical documentation with Paul Madden, if you're there.
I'm here. Thank you, Alex. So hi, everyone. I'm Paul. I qualified as a PA in Wolverhampton about 2 years ago, and I moved down to Cornwall where I work in general practice, and I'm one of the ambassadors for primary care. So as you said, I'm going to discuss medical documentation, because if you're anything like me when you first start, I looked at the screen and thought, to be honest, I have no idea what to write or where to start, so hopefully this will help. Next slide, please. So it's really important, and the GMC recognises that you must record your work clearly, accurately and legibly. Gone are the days where we would just write, or doctors used to just write, cough, antibiotics given. We need to write what we're doing, write down the history that we've taken, so it's clear for other practitioners that are accessing the notes to see what's been going on, how the patient is being cared for, and what investigations are due or have been done. I would keep away from abbreviations. I mean, sometimes you look at notes, you're going through the notes and you see these 3-letter acronyms that are written all over the place. And yeah, okay, when you're doing the abdo and you write SNT, we all know what that is. But there are some that are so, you just don't know what they are. And it doesn't help anyone at all, to be honest. There are sometimes, I've noticed in trusts in certain general practice that they have their own, abbreviations that are accredited to be used. So have a look around, and to be honest, I would only use the ones that are there. Now, good notes improve patient care. So if you can write down exactly what's been going on, and as I said earlier, someone can come along and see what the plan is, what's been going on, and there's a flow of consultations that you can skim through and have a look at the preparation of what the patient's coming in for will help and benefit everybody. Many times I flick through notes, and again the odd sentence, and it's not clear what's going on, and it doesn't help the patient very much, to be honest. It doesn't help the practitioners either. So again, just be clear and write down as much as you can. And remember that what you're writing down, you may need to refer to it later on. I mean, heaven forbid, things might happen and you're called up to sort of ask what you've done and why you did it. And I think if you've documented clearly a proper history, and you've documented your findings that you can go back to, refer to that, It will jog your memory as well, because I'm sure, 2-3 years down the line, if you're asked something about that patient, you're not going to remember who they are. So remember, good notes. And I was told from day one, if you don't write it down, it didn't happen. So it doesn't matter if you check their blood pressure or you listen to their chest. If you didn't write it down, it didn't happen. So make sure you do write it down. It's important. Next slide, please, Abel. Thank you. Now, it's beneficial when flicking through the notes to know where you were, what setting you were when you were seeing that patient. So always be clear at the top, you saw the patient at home or it's on the telephone, especially now during the pandemic. We're doing a lot of work in primary care over the telephone, and it's a different consultation. So just when you're flicking through and you can see that someone has spoken to this patient over the phone, and you can understand why the decisions are being made, and that the plan they put in place might be different to that if they were seen face to face. So again, it just helps to understand. Another good point is if someone was in the consultation who accompanied the patient, ask who they are, document that they were there as well. I've got a funny story actually. One of my clinical supervisors called a patient, and 2 people stood up, walked into the room and sat down. He did the consultation with the patient that was nearest to the desk, and then turned to who he thought was the wife's husband and asked if he had anything to add. And he sort of looked up and said, to be honest, I don't know who that is. I thought that this was going to be my consultation, and I was too embarrassed to say otherwise. So be careful. Things like that do happen. So if someone walks in, just clarify who they are and document clearly that, again, that they were there. Another good thing to remember is that patients will come in with multiple problems, sometimes 2, 3, 4, as I'm sure you've all seen on your training. But you be careful not to sort of just write one paragraph of everything that they've come in for. I know on primary care systems like EMIS and System 1 that you can actually mark out the different problems and do separate histories, which again, if the patient's coming back in and they come in for one of those problems, you can just go back to it, refer to it, and you've got that good flow, rather than spending a minute or 2 in the short time you have trying to pile through that paragraph of 3 or 4 different problems. And it's just making life easier. When you've documented it and you've saved it and you need to go back and amend it, never delete anything. I mean, legally don't delete it. Everything is audited. Every single key that you pressed is saved on there. So don't delete anything. Always go back in, amend, and if something is wrong or you've put it in the wrong area or it's the wrong person, just write a note saying, mistake above, and this is how we're going to amend it. Next slide, please, Abel. Thank you. So when you're doing your histories, write a thorough history down, put it onto the system, and do your positives and write your negative findings. So people can see, especially when you're learning, they can see that you're actually taking a thorough history, that you are writing, that there was an example of if someone comes in with a bad knee, you can sort of say, it's not locking, it's not giving way. Put those negatives down, and because it backs up that you've done your history and it takes your plan to somewhere else. Where am I? Sorry. Oh yeah, and again, when you're documenting, you might find, again, going back to the patient with the knee, they've come in and you've noticed they've got a bit of a cough, and you might think, I'll just listen to the chest. Listen to the chest, and writing down that the chest is clear, is fine. You don't really need to go into much detail with that, as they've come in for their knee and you haven't really taken a respiratory history. But if you have got a respiratory patient that's come in with a cough or a sore chest, be clear, write everything down, that you've listened to the chest, you've checked that there's equal air entry and expansion, and show that you are listening and that you do know what you're trying to listen for. I think that's important, because if you just write chest clear it doesn't always answer every question, especially with a respiratory patient. And what I would say is, if you were in doubt and didn't know whether it should go down on the notes, just write it down. It doesn't matter. It is much safer to have more on that documentation, on that patient's notes, than very little. Next slide, please. So I think this is really important, especially for someone that's learning, and I hope to just carry it on and show your thinking in the plan, why you've considered the differential diagnosis that you have, because you may have a thought of 2 or 3. For an example, you may have a patient who's coming with right iliac fossa pain, and they've done some heavy lifting, and you've got a differential of appendix, just muscular pain, or or a hernia. Write down why you've gone for one over the other, or cover for all 3. I think it's very good. So when you've gone back, and even if you were wrong, you can show why you went that way, and you've got an answer for why you did it, and then you've got no problems at all. You've done the right thing. Same with medication. Again, always say why you've chosen a specific medication if you're prescribing or you're advising a prescription. As an example, you could have someone that's had a leg infection, cellulitis, and was given flu clogs, had side effects, and you've tried another medication, probably clarithromycin, but there's so many interactions with other medications. You've gone for, I don't know, what would you go for? Doxycycline, and right on there, had side effects from flu clogs. Clarithromycin had too many side effects, so I've gone with Doxy. Patients aware that there may be more. It may take longer for it to heal, but they're happy for it, and that's why I've gone for it. And so much can be from that sentence. You can learn so much when you go back in as the second practitioner, because you can see that they've already been in before. They've already had antibiotics. They've been seen twice, and they've ruled out other things. So just document why you've chosen certain things, and always put in what you want to do next to make it easy for you if you're following up the patient, or if you'll send them to the GP or another practitioner. Put in there that if this doesn't work, maybe we should consider an ultrasound scan or an X-ray, or consider an alternative antibiotic. Put that there. Again, it shows your thinking, and it allows someone to pick up where you've left off. It again is really beneficial. Again, in your plan, if they need following up, write that they do. I follow someone today. I tend to follow up over the phone, so I will say, saw this patient today. We're going to watch and wait. However, I'll catch up with them on Friday. Put it into the notes, or you say this needs a GP follow up, and say the length of time, so that you task yourself and remind yourself that this patient needs following up. And many of the time, you'll see at the end of the plan, you'll just say, you'll just see safety netting. My advice would be, is what safety netting have you put in place? If you've got someone that's come in again with right iliac fossa pain, you can turn around and say it's an early appendix. So safety netting is in place regards to the signs and symptoms of appendicitis and their plan. What does that patient need to do to take control of their health there? So you say to them, it's over the weekend, you've got the out of hours, you've got to present to ED if there's any problems, and write that clearly, that you've advised the patient what to look out for and what their plan is and how to look after themselves. Next slide, please, Abel. This is just the legal framework. I'm not going to go into these acts in any detail whatsoever. Just be aware that patients can see what you write, and now with technology they can use, I don't know what the app is, but they can use an app or go online and actually see the consultations of what you've written. So be careful with what you write. There is an exception. So what's a good exception? If there's a safeguarding situation with a child and the parents have access to the notes, obviously if you've got those concerns, you will write them down clearly, but you can, especially in primary care, you can hide what you've written about that safeguarding note to ensure that the parents or guardians can't access it. So whichever system you're using, you might want to just clarify and ask about that, it might be useful for you. Next slide, please. Thank you. So in conclusion, you need to be clear and concise with what you write. It needs to be legible. You need to have your plan where someone can see what you've done, show your workings and where you're going. And like I said earlier, if you're in doubt, just write it down and put it on there. You know, no one minds. It's the best thing to do. And again, remember, don't get writing anything that you wouldn't want someone to see, because patients are now more and more so, especially younger patients, accessing their notes. Next slide, please. I think that's... So yeah, that's me. Sorry, all over the place, but thank you for listening, and I hope you find that beneficial. Thank you.
Right, thank you, Paul. That was really interesting, really important as well. Documentation, so important, as Paul said, but lots of things to touch on, really. That, everyone, was our last speaker. So, Abel, I think we've just got a question slide next, haven't we? But this is really the time for all of our speakers to, if you like, come back online. Now we had Eden, Ross, Abel, Jim, James Willis, and Paul. We're also joined for the Q&A by Beth Norman. Beth Norman's another experienced physician associate in secondary care, but she's got lots of experience to share as well. So all of us are here to help sort of answer your questions or have some discussion. Just on going back to the slides here, we do have a feedback option. We would really like some feedback on this event. This is our first event that we've run as the Southwest Physician Associate Network. Obviously, we want it to be open to Southwest, but you know, other people as well. So please please use that link, go onto that website and give us some feedback. As we know, feedback, being able to reflect on things is really important for everyone, for us moving forward. But we want this to be a rolling type of event. We want to start many more events to both support and increase networking throughout the Southwest and probably wider afield. So, how are we all doing? We've got 30 of us in here. I do understand it's 7:30 on a Friday evening, but come on, any questions? I'm sure you must have written some down. I've written a whole host of questions down if you haven't. Here we go. Good. So, thank you, Wakir. So if during primary or secondary care you are totally unsure about a patient's symptoms diagnosis, what would you say is the best thing to do? So that's all out to our speakers, really. So totally unsure about a patient's symptoms diagnosis, what would the best thing be? What would you say the best thing is to do initially? Good question.
I'm happy to take that question if you like. I don't know if it's geared to someone specifically, but I think that we've all encountered this in one shape, form, or another, and I'm quite confident in being able to speak for all of us that the most important thing that you need to do is ask for help. There's no shame in it. As I alluded to a bit earlier on some of my slides, is you can't be expected to know everything. And we work as a healthcare team. So that's doctors, nurses, allied health professionals, admin, ward clerks, everyone. We are all here to serve our patients. So the expectation is not that you should have the answers to everything. Obviously, if there's, depending on what your specific questions might be, I would try to urge you to try and figure it out yourself first if you can. But if you really do feel that you are in the deep end without any paddles and you're really struggling, ask for help right away, whether that's just from your colleagues who might not have much more experience than you, or whether it's from senior clinicians as well, whether it's a registrar or consultants as well. We are all there to try and achieve the same goal, which is obviously caring for our patients. And if you are unsure about a clinical scenario, about a diagnosis, about a management plan, within medicine in general, there is quite a fair amount of uncertainty as well. That's kind of comes with the territory. But I would really strongly implore you to just ask for help.
Just touching on what Abel has said, important to realise as well that even our senior clinicians and supervisors seek advice from one another. So that's the reason we've got multidisciplinary team meetings. So there's no shame in it, and it's what everyone does, and that's how teamwork works, especially in secondary and primary care.
Thank you, Ross. Thank you, Abel. Yeah, we've had a thank you already from that question. We've got more questions coming in as well, but I want to just add to that. It was along the lines of Paul, so our last speaker, he was talking about documentation of perhaps of important negatives as well, and that can really help guide your thought process and where you're going with this. I would say that's really important to consider, not just documentation, but think about what's there in front of you, that if you're uncertain about what could be going on, think about what there is that you can essentially look to rule out, or look to exclude. That can help refine some of your differential diagnostic thinking. That's just something I was thinking about there. Paul, were you going to add anything there?
Not really. No, I think
that's okay.
To be honest, I was going to say what Ross said, if I'm honest.
Yeah, absolutely. Well, thanks very much. We've got more questions here. So, a question from Nancy. So, to everyone here, do we have any tips for newly qualified PAs? For example, things to help with the transition. Thank you, Nancy. Good question. So, out to everyone, any tips?
Yeah, I'm going first on this one. I think the key things that I found when I transitioned from a student PA to a qualified PA was making sure that I was approachable, friendly to the team, welcoming, available to be asked questions, but also to ask questions to others as well. And to draw upon the talk I gave earlier, I was fairly clear in my first job in secondary care with my clinical supervisor about what kind of relationship I thought we were going to have with each other. And I've been fairly clear with my clinical supervisor here in general practice about the type of relationship that I think, you know, we need with each other. I think learning where things are kept, knowing who to speak to get certain things done, are things that you will just pick up by virtue of being on the wards or being in the practice. But those are kind of the skills which aren't really taught to you at PA school, but are the fundamentals of, you know, your day-to-day practice when you do transition. So going out of your way to make a note of where certain things are kept, what telephone numbers put you through to different directories, what bleeps are held by certain registrars. All of those things can only help to make your transition a smooth and pleasant one, I would say.
And I guess, hello everyone, so my name is Beth and I'm a physician associate. And first of all, I just wanted to say thank you so much to all of the speakers for all of your presentations this evening. I think they were absolutely fantastic, and I definitely wish there was something like this around when I graduated as a PA. So thank you very much for putting together and hosting this evening. And I guess to kind of slightly change Nancy's question somewhat, I guess one thing that's really important for you guys as you're about to become newly qualified PAs is actually when you're thinking about the jobs that you are applying for, it's not just about making yourself applying to a certain job, but you need to think about what can the trust offer you, how can the trust support you, and that kind of touches on what people have spoken about tonight in terms of developing relationships with your supervisors. I know that Abel spoke about trusts having a certain number of CBDs and mini KEXs for you all to complete. But I think it's just really important that when you are applying for a job, you've got to make sure the job will be supportive of you. Are you going to have regular sit-downs with your supervisors? Are you going to have PA-specific teaching? Do you have study leave? Is there a study leave budget? So I'm sorry, I know that, Nancy, that's not really answering your question, but I think those are just some really important things that you guys need to consider, which can help make your transition a little bit easier. Thank you, and that was just all I wanted to add to that.
No, Beth, that's really great to hear from you, and welcome, really join in here. Really good to hear that. Thank you, Nancy. Really good points, yeah, absolutely. Does anyone else have anything else to say on that? Or more questions in the chat?
I think I was just going to put the question back to Nancy really and ask if there's anything in particular that worries you, or is at the forefront of your mind that we can help with. Your question was very broad, and hopefully, Beth gave some very good information there, and hopefully some of what I said was helpful. But is there any kind of one specific thing that worries you at all? Just adjusting. Okay. In the sense of, going from being a student to a professional, having responsibility, or not knowing everything. Okay, that's very natural. I'm sure the other PAs can touch on that as well. It is a very natural feeling to have. And it does settle with time, and it settles with you growing your confidence by working with people around you, and by learning on the job, and by putting into practice all of the consultational skills or the clinical skills that you developed over your 2 years of training as a PA. So it's very natural to feel that way, but rest assured, I'm sure the other PAs will agree with me on this one, that it does fall into place with time and with confidence.
Yeah, thank you, Jim. I completely agree. Sorry, everyone. Completely agree. Can't know everything. It's not about being able to know or remember everything when you qualify, actually, and moving forwards. It's about having developed a skill set, almost like a toolkit that you can carry around with you. So be that history, be that clinical reasoning, be that examination, and so forth. So it's just having that and applying it to the different situations and settings, patient presentations that you come across. That's the thing that you will need to make sure you become really solid at and consolidate on. Thank you. We've got lots of questions coming through now. I think, where did I get to? So thank you. So actually, the next question, I've seen a few posts for the qualified PAs, more so the newly qualified, which are rotational posts, similar to foundation doctors. There isn't much information about them, however. Do you know much about them? So any of the speakers, do we know much about rotational posts? I'm thinking maybe Yeovil.
Yeah. So Beth and I both work in the same trust, and by all means, please feel free to jump in, Beth, if I'm saying anything incorrect. As far as I'm aware, when we first came to Yeovil, there wasn't a concrete plan in place for us to be rotating. And this almost sort of feeds off what Beth was alluding to, in that having a look to see how your trust can help you develop and how they can support you. One thing that we wanted to try and get across and try and develop within the PA role within this trust, because we were one of the first ones to get there, was developing a rotational system so that we can get a bit more experience and a bit more exposure to different clinical practices, clinical settings, before we sort of decide to pick a niche that we're quite interested in. I think it's important to, if there is anywhere that you are looking to join, predominantly whether if it's a secondary care trust, would be to have an open dialogue and open that discussion to the possibility of rotating around different departments. It wasn't something that was set in place before we got there. We sort of merged and sort of built it as we were going along. But it's a win-win scenario as well. So, and that might be something that you might need to present forward, saying that, by developing more experience and more exposure in different areas, you become what you can bring to the department which you finally decide to work in would be more skills, more experience, which would then help the trust, obviously, but also it would help your own development as well. So I don't know if there are specific job adverts which are advertising rotational posts, but I wouldn't be discouraged in that if there aren't, it might be worthwhile just to speak to the institution that you're looking to work in and see if that would be a possibility. You can almost tailor it towards a sort of internship year where you spend, a couple months in 3 or 4 different departments, rotating around before you sort of anchor down somewhere a bit more permanently. Ours was quite open to that, So I don't see why there would be much challenge or much resistance in other trusts across the country, if that helps.
Yeah, and I guess I'd just like to add, I mean, I completely agree exactly with everything that Abel has said. Though we at Yeovil have always done rotational posts, and for our newly qualified PAs, we put our newly qualified PAs through a 2-year rotational programme with the idea that at the end of that 2 years, they then remain in one place. But as ever, there is flexibility with that. That being said, though, if the offer of a rotational post isn't there and you can just go into the job offer is, for example, I don't know, to be a gastro PA, that's absolutely fine as well, because I think once you've been working in a trust, once you've been working in an area for a while, then when you're in the trust, you might then be able to start kind of thinking and having discussions about, well, actually, you know, maybe can I do a 6 months secondment to somewhere else? And I mean, just to give an example, for example, at Yeovil, one of the things that we offer is if you have been working in a department for 6 months or so and then you rotate, there is always the possibility that you can keep spending 1 day in your previous rotation. So say, for example, I just finished my rotation in the emergency department and I then went to orthopedics for 6 months, and I kept working in ED for 1 day a week because I was very clear that I wanted to make sure that I was still seeing a wide range of conditions. And the trust will really, really open to that. And so I am a big believer in don't ask, don't get. And you're never going to know if these things are possible if you don't ask. But it's just about forming an argument and making sure that there are very clear benefits for both you and the trust with all of these things.
Yeah, thank you, Beth, and thank you everyone else for answering that question. I hope that I hope that helps. Yes, it does. Yeah, I would sort of agree with both of you there, and sort of to reinforce that, I would say there is the option as a physician associate to develop much more of a portfolio career where you sort of you have different areas that you're working in it almost throughout the week, and starting off with a rotational with some rotational posts really could help get your foot in the door with that and other aspects. Sort of reflects that. And I haven't heard, I've heard good things about the individuals that have that sort of career. Actually, it's another option. It's another potential benefit of this role. We've got another question from Hayden here. So thank you, Hayden. This is a really good question as well. So it's for everyone. Jim Willis had to go. He got kicked out of the room there. So for everyone that's still here, what have our experiences been in terms of the progression within the role? So as opposed medicine, it's very clearly defined. Not so for us. So great question about progression. What's our experience has been? So anyone want to start the ball rolling? Chip in.
I was going to say I don't mind having a go, and then everybody else can then just chip in. So I completely agree that what all of our careers are going to look like in 10 years, it's very difficult to say. And when you compare that to medicine, and that most people, the F1, F2, F3 maybe take another gap year and then they'll go into specialty training. That's not something that as PAs we have. And I personally think that's really exciting because that means we have a massive amount of control over our career. I mean, for example, as Abel and I both qualified from the University of Plymouth course about 4 years ago. And, I've only been working for 4 years, but already I work clinically 3 days a week. I also work at Yeovil as the lead physician associate, and I teach 2 days a week on the Plymouth course. So, I've been able to create a fantastic variety of different activities within my working week. And I don't think there are many other career choices which can give you that option, and just of having just such a variety of things that you can do. So I realise that that's not necessarily a vertical progression, but you do have the opportunity to, say, kind of progress well and move laterally in the PA profession. I think that's absolutely fantastic.
Yeah, thank you, Beth. I'm going to completely agree with Beth. We're all agreeing with each other. That is that lateral progression. It's almost that sideward progression that you need to sort of start to think about or be willing to sort of acknowledge and appreciate, because you can get vertical progression within those particular areas you're in as well. It may not be, as you mentioned, as laid out or as hierarchical as some other professions. like nursing doctors, so forth, but you get the option of having that lateral sideways progression as well, which just opens the door incredibly so.
Alex, I just wanted to add on to that about expectations again, and about when you start a new post in a general practice or in secondary care, about setting the expectations with your employer about what progression that they expect and what you expect, and to almost try and get that in writing early on, because it's quite easy to fit into a role such as on the ward, and you're constantly putting out fires all day. And because you're really good at that, they keep you there. But it's really good. So I've just started a new role in a geriatric department, and in the first week sat down with my employer and come up with a plan for the next couple of years about where I want to be, what days I want to spend off the ward, and what opportunities, if they arise, I'd be able to take. So that's just something really important to think about when you're starting. And I know that they're quite difficult conversations to have, especially if you're brand new to the profession and brand new to maybe working clinically in the NHS. But again, it's all about that transparent communication with your employer, and they want to keep you, and you want to feel valued and keep progressing. So at the end of the day, if you can make it a win-win for everyone, that's what we're aiming for.
Thank you, Ross. Good point to pick up on. And Hayden, I hope this helps your question. I'm sure it does. But I'm going to follow on with that. Ross, specifically, you were talking about employers' expectations and so forth. And if you hadn't mentioned it in your talk, you've been rotating through. You've been going through some different GP surgeries in the sort of geographical area, almost showcasing, if you like, what physician associates can do in primary care. Ross, so having seen different practices and been, very new coming into them, you must have had a variety of experiences of different expectations or almost expectation mismatches. If you did, were there any sort of particularly common themes that you could pick up on with that, Ross?
Yeah, no, absolutely. I think there were definitely a main theme or a main expectation that each employer had, and what they expected from me. Again, before I came to each practice, they would ask me what they should expect from me. So I did set those expectations initially, but I spent a few months down in Lou, and they wanted to focus on me doing all the home visits. So that was my job for the month that I was there, trying to attend all the home visits for that practice. And the next practice I went to, they had a really busy kind of on-call list and wanted support going through the calls, acute calls from that day. And then another practice I went to wanted a really big focus on care home and nursing home virtual ward rounds. And that's what I spent a lot of my days doing as well. So the good thing about being a PA is you can be flexible, and you can hopefully adapt and fill the little gap in the market that practice has, and find your value within that team.
Thank you, Ross. And I know sort of we've got a couple of less people in the room now in the meeting. It is, do obviously feel free to drop out and carry on with what you're doing. But for those that are still in the room, please carry on with some questions. And I hope you found that question interesting and useful. I mean, all of us have some, different experiences to talk about, and of course, as Abel was just put up, don't forget about our feedback form. So, anyone still in the room, if you've got any questions, please jump in the messages, put your hand up. Feel free to turn your microphone on, or else I'm going to keep rolling through some questions that I built up. Abel, if you're still here, yes, you are. Abel, so you were talking about the portfolio, and certainly that there's a variety of portfolio platforms. You mentioned one of the ones you used in Yeovil in the hospital there. So talking about the different things you can do in a portfolio, or you have to do, so work-based assessments, reflection on practice, appraisals, so forth. Which have you found the most useful for your own professional development, do you think? Well, that could be to anyone, couldn't it, really?
Yeah, it's a good question. I don't think I've ever thought about having to rank them. I think for my personal sort of professional development, mini KEXs have been very helpful because they make a big part of what your clinical activity involves. So actually, you know, going through the notes and coming, you know, trying to get the story behind why a patient has come to hospital and what's been going on. Taking that information, obviously going to the patient and almost teasing out more pertinent, relevant bits of information, which you then, it's almost like putting in, you know, making a puzzle or sort of a jigsaw, where you need to tease out little bits of information from your history, your clinical exam, and also your rationale in your thinking process, which is directly observed by someone else, who then can give you feedback on that. I think as the years have gone on, I found that my getting feedback on my clinical reasoning and judgment from, you know, being seen how I assess someone has been quite helpful, because they can essentially, you are showcasing all elements of clinical practice: your communication skills, how you take a history, your examination skills as well, and also your diagnostic and management, you know, plan is all put under the microscope by someone who's quite experienced, you know, quite senior, and really they can help you or guide you in the right direction if you're not, or if you are heading in the right direction, try and, you know, ask more questions to try and develop yourself a bit further. So I think mini KEXs are quite helpful. I would say DOPS forms for sort of extended procedural skills, I think those are good things to have. I wouldn't say that they're most important. They're quite helpful for now, at least just getting some evidence written down saying that, you know, you've done X number of lumbar punctures or chest drains. So then when regulation comes through and you know, later on for the GMC, you have that evidence written down. But I'd say mini KEXs and probably case-based discussions are probably the two most helpful parts of workplace-based assessments that I've done, which helps me develop.
Thank you, Abel. Yeah, that was a good question and good answer. Thank you. I mean, I don't want to take over here. Anyone else in the room, anyone else that's still here, please, if you've got any questions, type them in now. I'm not going to keep you for much longer. Here we go. So thank you. So the question: any red flags we should look out for in terms of vacancies where employers may not offer as much support for newly qualified physician associates, and therefore sort of throw you in at the deep end? Have there been any examples of this happening? Yeah, that's a really good question. Really good question. That's really important. I would say from the get-go, just to get this started, red flags with a particular employer might be when they're in their job description or their description on the website that they're in. If it's just really, if it's very short, if it's really limited, and they're not really talking about the full breadth of the scope of practice that the physician associate could do, if they're not talking about sort of support, potential developments in terms of like a long-term plan, it might be an indicator. That they haven't really got as much of an insight or understanding into what the role can offer. But over to anyone else here, because I'm sure anyone else has other things to say.
Yeah, I mean, I guess one thing that's really important to look out for, which kind of touches on really everything that we've discussed, is if there is a job which is advertising for a PA or a nurse practitioner or an advanced clinical practitioner or some other kind of role, you want a job which is specific for a PA. We are our own profession, and we need to embrace that we have our own professional identity, and you very much want to be working somewhere that appreciates that, and also, with that in mind, can then be able to support you properly. Really, I think that's really, really important, because we are our own profession. And in terms of kind of being thrown in at the deep end, I think the day you start working, it is always going to feel like you're kind of going bungee jumping. It is always going to be really, really stressful. But as everyone else has said, it will get easier. But I think it's really just about making sure that you are supported from your team, you've got support from your consultants. But I don't know if everybody else, feel free to jump in, but I don't think a PA you should never be by yourself on the ward. And I know that some trusts do work a little bit differently, but at Yeovil, the way it works at the moment is our PAs are technically supernumerary on the rotas at the moment, just because obviously we can't prescribe if there is an emergency. We aren't able to prescribe those medications, but we can, obviously facilitate lots of different things. But I don't think PAs should ever be on the wards by themselves, particularly when they're newly qualified. I don't know if anyone else has got anything they wanted to add to that.
I was just going to add, and it's not so much a red flag, but rather a green flag. if you're joining a trust or more likely a general practice, and they already work with other professionals such as clinical pharmacists, paramedics, advanced nurse practitioners.
Ross, we might have lost you there.
Can you hear me now?
Yeah, I can hear you. Yeah.
So I was just saying a green flag might be, especially if you're going to general practice, is if that practice already works with other professionals such as paramedics, pharmacists, advanced nurse practitioners. Because if the GPs are experienced with working with other professions, then there's a lot more chance to have an understanding of the PA role.
I think we may have lost Alex. I think his computer may have frozen. I'll just open up chat, see if there's any other burning questions that might be left.
I think if there's no more questions, that's probably quite a good time to start wrapping up, I think.
Yeah, I think so.
So thank you everyone for joining our evening talk. This is the first one we've done. Hopefully if you enjoyed it, we'll set up another one in the future, and we'll make sure that we upload this talk onto the Physician Associate Network's website and YouTube page. And we put the link in the chat. And again, just one last reminder, if you could fill out one of our feedback forms so we can reflect on that and decide whether to do something like this again. But thank you everyone for speaking, and thank you for answering all the questions. And we look forward to seeing you all again and getting together at some time in the near future.
Yeah, thank you all very much. Yeah, Alex has just said his internet's gone, so I think this might be a good place to wrap it up. So thanks everyone for joining in. I hope you have a good weekend.
Have a great weekend, everyone. All the best.
Okay, bye-bye. Oh, have you come back, Alex?
Yeah, I'm back
Okay.
now. Yeah, the recording is still saved. It's still very
Brilliant. Okay, good.
Sorry, yeah, it's just me and you now in the room.
That's fine. Yeah, no, that's not a problem. Yeah, I told them that your internet packed up, so that's fine. Awesome, cool. That went well.
Yeah, that was really good. I don't know what happened with my internet. Did it cause a problem at the end there?
No. It was absolutely fine. I think when you said you couldn't hear Ross, I could still hear him, so I figured that's what it was. So yeah, we just kind of concluded and wrapped it up.
Lovely.
So
I'll stop the recording. Sorry, let me stop this recording.
Do you know if there's a way to get a list
Hang on,
of?
I'll stop the recording.